Good morning and welcome to this joint meeting of the Criminal Justice Committee, the Health, Social Care and Sport Committee and the Social Justice and Social Security Committee. So we've got no apologies this morning and we have Claire Haughey joining us online. So our first item of business this morning is to decide whether to take item 3, which is consideration of evidence and the legacy paper in private. Are we all agreed? Thank you very much. So this morning we're going to hear from two panels of witnesses. So first of all, I'd like to welcome to the meeting Dr Saket Priyadarshi, Glasgow Alcohol and Drug Recovery Services, Kelda Gaffney, Glasgow City Health and Social Care Partnership, Tricia Fort at Culton Community Council and Steve Baxter with William Morrison Supermarket Limited. So you're all very welcome and I refer members to the papers circulated for this meeting. So due to our time constraints, we will move straight to questions. So I wonder if I can open up with a bit of a scene-setting question and I'll maybe come first of all to Dr Priyadarshi. So I wonder if you can maybe just open up by providing some information in terms of the figures that are published, setting out the number of service users injecting episodes and the type of drugs that you're seeing being used at the Thistle project. So, for example, are the levels of service users and injecting episodes as you would have anticipated them? So over to you.
Good morning and thank you for the invitation to give evidence today. We provided a data report to the committee yesterday with the most up-to-date figures up till the 30th of September this year. And up till then we had seen over 400 individuals, 461 unique individuals had registered to use the service. And they had used the service over 7,000 times, and there were over 4,600 injecting episodes within the Thistle itself. The injecting episodes are probably an underestimate of actual injections, because the injecting episodes are counted as every time a booth is used, but a booth may be used, an injecting booth may be used more than once for one injection per each visit. So we're likely to have had over 5,000 injections there. The balance between the different drugs that are used in the service is very much skewed towards cocaine injecting. Over the course of the 8 or so months since the service has been operational, there's probably been about 70% of injecting episodes related to cocaine, which is significantly different than what would have been the case when the original business case was presented 8 years ago. There's very significant drug trend changes in the city and an increasingly changeable and volatile drug market within the city. We've seen 60 medical emergencies in the Thistle, and those 60 medical emergencies have been managed with positive results for individuals. They've all recovered and they've come back and used the service again. Of those 60 medical emergencies, just to say that those medical emergencies are quite heterogeneous, so they're not all the same. Some are relatively easier to manage in-house with airway management and oxygen, and there are others which are much more at the severe and that required a much more intensive medical emergency treatment. We've required to use the ambulance service on 11 occasions, and on 7 of those occasions the ambulance supported service users to hospital. So in terms of initial sort of review of that, that's 5,000 injections happening inside the service that wouldn't have happened in other places, particularly away from home, outdoor places, and those needles have been discarded within the facility rather than outside in public places. And that's 60 medical emergencies that have mostly been managed in-house with positive results. So there were some very severe medical emergencies, probably at the time when nitazines were in the heroin supply in Glasgow, and those undoubtedly would have had a very, very high risk of fatalities. Yeah. But equally, through the in-house management of those medical emergencies, the ambulance call-out rates are probably significantly less than if those individuals had overdosed in public places or in hostels or other areas. And the hospital admission rates for those are significantly less as well, I would imagine. But those things will be measured through the formal evaluation. In terms of your questions around how this matches expectations, I think the surprise for us has been the balance towards cocaine in terms of the injecting episodes inside, and now we understand that reflects street drug trends in many ways. And the coverage so far in terms of number of people using the service on a daily basis, that data suggests that continues to increase. So September was our busiest month so far, so it's a promising start. But I think we still have some way to go to improve the coverage of usage of the facility for people who are currently injecting away from home in the East End and the city centre.
Yeah, thank you for that. And certainly we saw some of that set out in the submission, which was very helpful in terms of the growing use, if you like, of this service. Can I just quickly ask a follow-up question? You know, you've spoken in your opening remarks there about drug trends, and obviously we're very aware of the sort of growing prevalence of nitazines. I'm just interested in what comments you may have on, you know, the way in which those trends are impacting on service delivery at the Thistle.
Yep. So we are seeing, if we take a step away from the Thistle and look at what we know about the drug market in the city itself, we're seeing a quite significant shift from injecting, and particularly injecting heroin, to smoking, and particularly smoking crack cocaine is rising quite significantly. We appreciate that there is heroin in the supply, particularly from, nitazines in the supply from time to time, but actually the extent to which we find them in toxicology and forensic toxicology, although is growing from last year, is still relatively a small minority compared to the other drugs that are found in toxicology. Yeah. We did have a cluster of very severe overdoses in March, April. I think this was experienced across certainly the Central Belt and in Ayrshire as well. We experienced them in the Thistle, so we were able to observe those overdoses. They required very intensive management, and they gave us the first observable clinical picture of those overdoses, because they were being reported nationally, but we didn't have, if you like, an objective clinical picture of them. We were able to get some drug paraphernalia from people and have them tested through forensic laboratories, and that provided us with confirmation that this wasn't just heroin, but heroin with nitazines. So I think from a drug trend monitoring perspective and an intelligence gathering perspective, the Thistle was able to play a significant role in building a picture of what was happening at that time, and we were able to share that information across our health board, but also across Public Health Scotland's national group that had been set up to manage the incidents across the city at that time, and that informed a drug alert. But more recently, we've been concerned actually about the impact of adverse atypical events for people who think they're smoking crack cocaine. And you'll have been aware of a cluster of overdoses that happened in the city centre. And some investigation into those seems to suggest that they have had, those supply may have had synthetic cannabinoids. In fact, they were confirmed as containing synthetic cannabinoids, very strong cannabinoid agents that played a very important role in the atypical and severe adverse events, some of which are likely to have been related to suspected drug-related deaths. So in terms of what the impact of that for the thistle and the development of safer drug consumption facilities, well, we're able to provide harm reduction advice to service users, but we really think that the importance that this amplifies the importance of drug checking services and adding a smoking inhalation space within our service as well, because that's where the drug trends seem to be heading.
Yeah, thank you. Okay, thank you for that comprehensive response. So I'm going to just bring in Paul Sweeney now, and then I'll bring in Sharon Dowie.
Thank you, Convener, and thanks, Dr. Priyadarshi, for your initial comments. I suppose it was promising to see the uptick in patronage and use of the facility over the last 6 months or so. I just wanted to establish some of the trends you mentioned around cocaine injection. So 70% present use of cocaine. Can you just maybe comment on the typical pattern of behaviour of cocaine injection, particularly the frequency of the episodes relative to heroin, and how that's presenting? Is there a greater velocity of injecting happening as a result of cocaine use?
Yeah, thanks very much. I mean, the first thing to make clear is that most people who use cocaine have at least a history of injecting heroin use as well. Most people who are injecting cocaine within our service have a long-standing problem drug use history, which includes injecting heroin, and in more recent times they've transitioned to cocaine as their primary drug, it seems. The pattern of use is different, absolutely. So people who use heroin will have fewer injecting episodes than people who use cocaine. Cocaine, to put it in very sort of layman terms, is very moreish. So when people start using cocaine, they often go on short binges, and the binges could last a day or two and involve multiple injecting episodes, whereas somebody with heroin use might inject 2, 3, 4 times a day. Somebody who's using injecting cocaine in the most extreme way might inject up to over 10 times a day. So we do see people coming and then coming back and again into the service over the course of the day. The other big difference for us is also we notice the pickup in the sort of later half of the day with that population and heading towards the evening as well. In terms of the medical emergencies, the vast majority happen in people who are using heroin, often heroin and cocaine together in snowballing, and they're the individuals who require highest degree of monitoring post-injection in the recovery area. People who use cocaine often transition through the recovery area quite quickly and leave the service and come back later. But as the day progresses, their presentations can change, and they do show signs of becoming affected more and more by the stimulant use.
So it's an interesting point that the frequency of injectings per person is increasing because of the change in behaviour. I just wonder, one of my concerns from the outset has been the restricted operating hours of the facility. So we know that there's been commentary around drug-related debris within the wider community. And anecdotally, I had the suspicion that this could be related to an increase in frequency of use rather than it being about an overall increase in the area of people using drugs. I've had recent correspondence, for example, from Matt Cordon at the Drygate Brewing Company, who's described anecdotally in the lady wells behind his business, significant drug-related debris overnight I just wonder what interaction the service is having with the council and other partners to monitor street injecting within the vicinity of the facility, particularly after closing, so from 9 p.m. to 9 a.m, and what potential adjustments to the service model could be delivered as a result of that observation.
So I'll kick that off, but maybe my colleague Kelda will have some comments on that as well. So obviously the first thing to say is that those injecting sites, many of them existed before the Thistle was opened, and actually by absorbing 5,000 injection episodes inside the Thistle, there's a degree of benefit there already by reducing the likely impact for the community, especially as people move from heroin to injecting cocaine, the increased frequency of episodes and the nighttime injecting that comes with that as well. We have a community engagement forum where we have a whole range of local partners who inform us about the sites that they're most concerned around injecting and drug-related litter. And we work closely with the Glasgow City Council's Neighbourhood Regeneration and Sustainability Service, which will respond to those concerns and go and clean sites that are in the public domain. As you know, private site, there's challenges around private sites, and actually NRS instituted a Calton action plan around improving the social environment for the community with regards to deep cleans of the sites that were identified and the placement of 2 drug bins that were placed, one in Calton and one in the supermarket, Morrison's, that the Morrison representative can speak to as well. So we all that work is going on, but also on a day-to-day basis, we have 2 outreach sessions from the staff at the Thistle, so in the morning and the afternoon. So when we heard about the Drygate, for example, and we heard very quickly about the Drygate issues, we were able to respond. Our staff go out twice a day. They try and engage service users or potential service users who are using those sites by giving them information about the Thistle as an alternative to those sites. And many of our new service user registration are the result of that outreach work, and by diverting people away from public spaces to inside. But undoubtedly, we don't, as I said earlier, we don't have full coverage of all injecting episodes for a whole range of reasons. And one of the reasons may be absolutely the operational times, and we're aware of that as an issue from staff, from service users. We have a service user forum, and they tell us that. We're only about 7-8 months into the service. There will come a time, I think, where we need to review some of the basic operational elements of the service, and I think operating hours will be something that we need to review at that time. Just to make clear, we did consider longer hours and overnight operating hours in the original business case. At that time, the number of overnight injecting episodes that we were aware of in the city was much less than it is now. And so the cost-benefit element of running an overnight service with a staff complement and everything that goes with it, we didn't think that the need reached the threshold of that benefit. But as I've explained earlier, and as you're alluding to, the dynamics of the drug market are changing, and if cocaine is the primary injecting drug, then it may be that we need to reconsider our hours, and we'll do that in due course. Kilda, I don't know if you want to add anything.
Just very briefly, because I do think it's a really good point and a good question. As Saket has said, we did absolutely look at the operating hours before devising the operational model, and that involved consultation with people who with lived and living experience, and that city centre population. But the trends have changed, so we will always keep that under review. The model that was proposed and obviously funded was absolutely based on that cost-benefit analysis and has to be moving forward. But we also engage with our partners fairly regularly. So as you'll know, there will be a reported evaluation, formal evaluation, but that's not going to report for another couple of years yet. So the discussions we're having internally is how do we report and record the outputs and any of the barriers and gaps along the way, and the operating hours is absolutely part of that. And so will be under consideration, continues to be under consideration, and we have a number of governance forums where we discuss the operating model.
I just wondered, there has been anecdotal sort of perhaps conflation, but I wonder if you could clarify. The Needle Exchange programme has operated in Glasgow since 1987, and you've described that the Thistle has removed, quite obviously, around 5,000 needles injections from the street environment. Is there a dispensing element to the Thistle in terms of sterile injecting equipment, and how does that operate, and how does that operate in concert with the Needle Exchange programme that, as we know, has already been well established in Glasgow? I just wonder if you could talk about how that works, bearing in mind, as we described, the restricted operating hours of the Thistle.
Yep.
Make your comments as succinct as possible. We've got a lot of questions to get through in slightly limited time, so if I can just ask for your forbearance on that. Thank you.
I'll do my best here. So yes, the Thistle does provide injecting equipment provision for people who register at the service and ask for that, or on leaving the service after injecting, ask for that. And it's the same injecting equipment provision that's used throughout the city, and it's a one-hit kit. And the rationale for that is that we're becoming aware that people, not all injecting episodes are inside the service, and we are aware that there's a background of HIV, hepatitis C, wound infections, and so it's a harm reduction measure, pragmatic harm reduction measure that we use. We can see that our injecting equipment provision does become more popular as the day goes on and into the evening as well. So again, that builds into the trends that we're seeing around injecting cocaine into the evening and night time.
Thanks.
Thank you. Okay, Sharon Dowie and then Alexander Stewart.
Thank you. Good morning. I'm looking at the impacts on businesses and the community. So could you set out some of the issues that businesses in the community were facing in terms of drug use prior to the Thistle opening, and what the impact of the Thistle opening has been on them? And if I could maybe ask Steve Baxter that first and then ask Tricia Fort.
Yeah, no problem. So there's always been an existing problem with drug use in the area of our store, and I can only speak to Morrison's in Barrack Street, linked to, I think, the Needle Exchange, which you've referred to previously. We've tracked the data very closely. We've engaged with the Thistle. We've engaged with the local authority. The particular issue that we suffered in our store was users taking drugs actually in the car park and in the surrounding curtilage, which is part of our property, and then the needle debris that came about as a result of that use. And we were seeing significant deposits of needles, which obviously had huge concerns for both our colleagues and our customers. The data provided to the committee demonstrates quite significant reductions in that needle debris recovery, which is a really positive step. I mean, you're down by, I think, 94%, 96% in terms of the needle recoveries that we in the store have seen, and we have a clear process around how we deal with them and how they're recovered and how they're reported. There's a qualifier there, and there's a slight underreporting of the needle recovery in store by virtue of some sickness and some leave over the summer period. But if you look at the results since the needle bin went in May, which we cooperate with the local authority around, I think it's the first local authority needle bin on a private site, the correlation directly represents the needles that were being recovered in the car park before that. So those are really positive things from our point of view. The anecdotal feedback from colleagues who have worked in the store both pre and post the Thistle is for the most part positive. They say that they see many fewer, incidents of drug taking in the car and around the car park, and that's obviously very disconcerting for everybody in the community because nobody wants to be seeing that. If you look at some of the examples that provided, you've had needles recovered in parent and toddler bays in and around our shop, and disabled toilets, which is really it's unacceptable, isn't it, to be perfectly honest with you. So they see many fewer of those. They're also clearly seeing very fewer needles being recovered in and around the car park, but it is still happening. And the 96 that have been recovered in the needle bin is 96 fewer that have been put in our bins. The one thing that colleagues do talk about is the increased footfall into the Thistle by strange people. It's a very tight community. People are well known. They talk about many more faces coming into the store, in and around the store, and the begging has increased in terms of we report incidents by virtue of we have a begging incident, but the number of individuals involved in that begging is where it previously would have just been one. It's now 2s and 3s. But that's something I'm picking up with the operational manager for the Thistle around, and he's very supportive.
See on the figures you've sent in, do you have a breakdown of what they are? I say it says all business incidents, just when you're saying there's been an increase.
Yeah, so they're all crime related. They wouldn't necessarily all be reported to police. So the overwhelming majority, about 50% of those, would be incidents where packaging is recovered in store. So there's been a theft, but there's no evidence of who committed the theft. You're not going to track back on the CCTV because of the volume of those incidents. So that would be about 50% of the incidents that we see in store. That'll be followed by your standard shoplifting, abusive behaviour to staff and antisocial behaviour in Barrack Street, which would be linked into begging and also some discarding of the needles.
And how big an impact is the under-reporting that you mentioned?
I would say you're probably looking at about 10% of under-reporting, specifically in relation to the needle debris. And also in addition to the incidents, because we had an issue with our freezers operationally, bizarrely, over the summer, which meant that our footfall was slightly down. So therefore there will be a natural reduction by virtue of fewer people through the door.
Okay, thank you. Tricia?
Thank you for inviting the Community Council along. Most of our evidence is anecdotal. We haven't the capacity to be collecting any figures. Now, I moved from elsewhere in the city to live in Carlton almost 9 years ago, and I was aware immediately that there was drug refuse. And at that time, the Simon community operated nearer to the Thistle, far nearer than it does now, quite near my home. And after a year or two, I started volunteering there, and I was one of the people who issued needles to people in the needle issue. So that upset a lot of my neighbours. And so I can only agree with what Steve has said, that there now do appear to be more people coming into the area. It was a fear beforehand that dealers would be moving in, and anecdotally that has been confirmed. And what else?
Come back to you, Tricia. I'm just conscious of time,
right,
if that's okay, because we've still got quite a lot of members want to come in and ask questions. So okay, if you're agreeable, we'll maybe come back to that. That's okay, thank you. Okay, I'll bring in Alexander Stewart and then Pauline McNeill.
Thank you. Can I just extend some of the bit with engagement, because it would be quite good for us to get a flavour of what has been happening with the engagement within the community and the business sector. And you have a community engagement forum that takes place, I believe, within the community. And if you can give us a flavour of what has been discussed, how things are being addressed within that forum, is that a vehicle that is being used and you're finding quite useful for the process and having to manage that situation within the community, or rather areas that you've got concerns about.
I don't think so. Is that addressed to me? Because I don't run that forum.
But is the businesses involved in the
The
forum?
business is engaged with the forum, yes. Sadly, we've had a change of managers in store since the beginning of the year. So we're now on to our third manager. So the continuity isn't quite there as we would like. The new manager is now getting fully brought up to speed. He's been across to the Thistle. He's met with the team there. I've introduced him to the local police. I've introduced him to the local authority. So at those levels, that engagement is good. We've encouraged colleagues, many of whom live locally, to attend the forum, given them that information. I'm reasonably confident the uptake's been pretty poor.
Okay. Trish, do you have an involvement with the forum? Does the Community Council have that?
Yes, I do.
Okay, so
I would say it is a very positive thing. The number of people involved has increased since it started, and I think there's some very positive engagement from people who were initially very hostile to the Thistle. People still have concerns, but there is good discussion. There was a meeting just on Tuesday, which Sackett chaired, and there was one new person who has also been coming to the Community Council meetings, and she had lots of questions about where she lived, and they were all answered and noted for further action. So I would say through the forum, through the discussion, through the involvement of the local authority and the police, that things are improving. So from before the Thistle was there, it was just, it's Carlton. You know, it's that rundown area at the east end of the city that nobody's concerned about. And that was definitely a view from people who have always lived in that area. But I think now the City Council are clearing areas where there has been drug use. The needle bins are being put there, as Steve said. Steve's figures are very encouraging. And yes, there is still concern. People are still seeing drug dealing, and it has moved round the area. We in the Community Council, and sorry, this isn't the Community Forum, but we involved the police when there was definitely drug dealing up near the Moxie Hotel, Havana Street, if you know that area. We've then had some Parsonage Square, which is further south, St Andrews Square, and then there's been drug taking near St Luke's. So it does move round because the police are following them. But I would say overall, good is coming out of what was seen as a big infringement on the area.
So there has been a change in the antisocial behaviour or drugs taking around the area. Have you both experienced that?
Well, I'm sorry, I'm not sure there's... I don't have that detail. There is still a lot of drug taking in and around the area. And I understand from people, you know, who've talked to drug users that there is some reluctance to use the Thistle on some people's parts. Obviously, some people are going along. And just on Tuesday, we heard from the outreach team who are being exceedingly positive and friendly, you know, and welcoming to drug users that they meet out with the Thistle, and encouraging them to start using it rather than injecting outside. So my personal opinion is that, yes, it is doing good. But as I say, and as I mentioned in the short paper I did, there is still a lot of concern. You know, we didn't have any involvement. It was just imposed on us. It was put there. And now we have to live with it.
Okay. Anything else from your side?
We would certainly say we've seen a reduction in drug activity in and around our store.
Okay. Thank you, Convener.
Thank you very much. Pauline McNeill and then Eleanor Whittam.
Thank you very much. Good morning. I just wanted to continue on this theme I know Carlton Well have been to the facility, and I'm aware that, I think Tricia Fort has said that a lot of apprehension of the local community, understandable. So I've noted what you've said already, but the media reporting seems to suggest that there has been an increase in drug-related crime, and I just wondered if that related at all to what you're telling the committee. I mean, is there any evidence that there's been a reduction or an increase, or which is it, do you think?
I can't talk to Police Scotland statistics around drug-related crime. All I can tell you is our experience, and our experience is that we have not seen an increase in theft, shoplifting or incidents in our store linked to the opening of the Thistle, and in fact we've seen a reduction.
Tricia, is that the view of the local community then?
As far as drug-related crime is concerned, I have no knowledge of that at all. People are concerned that they see drug taking itself and they see evidence of it. But then that has been the case for many years. I don't personally know whether it's gone up, gone down. It's certainly moved.
Okay.
Could I make one point on that in terms of the media? Sorry, could I just make one point in terms of the media? So obviously this is high profile in terms of Morrison's, and our media team received complaints in terms of social media posts that are made. Initially, when the centre opened, there was a huge wave of social media. We have not had much contact at all in respect of concerns raised on social media in recent times.
Dr Priyadarshi, I think you want to just come in on this?
If I can, very quickly,
Please, yeah.
Police Scotland are very important partners in the Community Engagement Forum and partners of the service. And when they've come to the forum and presented their data, they've confirmed that there's no evidence of, or no clear evidence of increase or changes in drug-related crime as recorded by them in the vicinity, and they're able to give that feedback to the residents and the other stakeholders in the forum. And I believe they've made a submission to the group today with regards to that and confirming their data. So I do think the media coverage is when we opened the service, it was more positive. At recent times, we can talk about the media coverage later if there's a question on it, but it has been challenging for us and has not been informed by evidence or by clear objective opinion.
Thank you. And so there was a specific issue that my colleague raised about drug dealing specifically. Does that include drug dealing?
So I'm not able, well, I think the drug-related data that Police Scotland present and have presented to the committee is likely to include drug dealing in its breakdown, but that's not something I'm able to answer definitively.
And just the way that you're engaging with the community, just to make, I suppose there's still a long way to go. It's only 7 months in, as you said. How regular is that contact with the community to keep them engaged?
The forum itself, the Community Engagement Forum, meets 6 weekly, and we meet one meeting during the daytime and one meeting in the evening, and we try and meet at different locations for those two to allow as many stakeholders as possible to attend. Some people work and can't attend daytime meetings, others find evening meetings difficult. As you've heard, I think it's a meeting that is valued by the members who attend, including the community, resident and business reps who attend. They are regular attenders. We've got registered social landlords who represent many tenants in the area as well, attending as well. So it is valued, it is taken seriously. They, I think, have confidence that the issues that they raise are taken seriously by the service leads and by partners, particularly Glasgow City Council and Police Scotland partners. So that's a forum, but on a day-to-day basis, we have made two of our senior officers for the service, the operational manager and the Thistle phone and email address available for contact, and we do get contact. So, for example, the Drygate issue was a phone call to us. We responded the next day immediately, and we had feedback from the registered social landlord that their tenants were really satisfied that that response had happened immediately. It was a visible response that they could feed back to their tenants. So I think it's a very active forum. As you've also heard, it's an opportunity for the community that in many ways felt marginalised before to work with a range of important key partners in the city about improving the social amenity. So the forum is almost like a vessel, a vehicle for that wider sort of improvement in the area.
Thank you very much.
Thank you for that. I wonder if I can maybe just highlight, just you referred to the Police Scotland submission, and what they've highlighted in their submission was that crimes of supply of a controlled drug or possession with intent to supply were lower than the same period in 2024, halting a 3-year trend of increasing offence numbers. So that's helpful clarification. Thank you for that. So I'm going to bring in Eleanor Whittam and then Annie Wells. Eleanor.
Thanks very much, Convener, and good morning to everybody. I'm interested in talking a little bit about referrals to and from other services, and actually how that's been developing over the course of the Thistle being open. And thank you for the information that was supplied in the submission with regards to this. And in that submission, it states it's likely to be an underestimate. But I want to put a little bit of narrative around about this, if we can, and think about somebody's journey prior to engaging with the Thistle and how those relationships are built up with other organisations, that kind of assertive outreach, and why it's perhaps important that somebody's able to come in and perhaps use the showering facilities, get to know people, and then the referrals into the other services. How important are those relationships? Because it's a long time from somebody in a chaotic situation to then engage in services and then perhaps eventually to start making use of residential rehabilitation. That journey is quite a long in period. So I wonder if you could speak to that. Kelda?
Thank you. And again, thank you for the question. So I think the very end, the very last point you made is an exceptionally good one. And going back to some of the media coverage and some of the challenges that we have, we have this ideology that you can somehow compare recovery and people coming into a harm reduction service at a point when they have not engaged with services for quite a long time, or experienced challenges in engaging with services. We know that the traumas that people have experienced, having had addiction issues, and drug issues for significant periods of time. We know that family relationships are disrupted. We know that the networks of support around people that you would hope for are not available to people. So the Thistle, we always hoped that was part of the business case, was around building those blocks around people, building those supports around people to allow them to be able to trust and access services. So again, we know from a trauma-informed perspective that when people have been through the circumstances and the situations that individuals who are accessing the service have done, that it takes, as you indicated, it takes a significant period of time to build trusting relationships, and we know that that's a vehicle for change. For most people, the vehicle for change is those relationships and trusting in people and believing that recovery is possible. Because at the stage where people are coming into the service, quite a lot of the time, when we hear that from people with living experience, don't actually believe that recovery is part of their journey. That can be a long journey for people. It's a journey that we would absolutely encourage people on. I would also say that recovery is different for every person, and you have to be individual when you're talking about recovery. One of the aspects that we considered very carefully when we were designing the service, and actually this was designed, as you know, was absolutely co-designed with people from our recovery communities, people who have experience of using drugs and injecting drugs publicly, was around that. What are the facilities then that we can introduce that encourage people to use the service? So the showering facilities, the laundry facilities, the ability to come into the service and use the IEP, for example, and we have many examples of that. People coming in to use services without injecting, but then returning to inject because they trust the service, they understand that it's a service that is compassionate and is caring and will allow people to take their time to do that. And we will monitor that as we go on, but that's why we have difference in those figures. And the final point I would pick up is that I think that's really important for women. So we know, and women are underrepresented in the service, we've got about 20% of the population are women. We know that women in particular are more difficult to engage with services, and we're doing a lot of work around that. So we engaged our lived experience women's group, were very influential in terms of those shower facilities, those laundry facilities, and looking at some kind of group work and how we engage with women. So I think it's really important to give people an opportunity to come into service, to trust the service, to begin using the service, to inject. Some of those people will inject immediately, some of them will take a longer period of time. We will then discuss with folk in terms of using the service, what is in their interest and what do they want to seek in terms of their recovery journey. I think, you know, again, going back to some of the reports, both in social media and media, I think they're conflated. You know, I think we need to understand that people who are coming into the service are not at a position themselves to enter into, for example, a residential rehabilitation. The service would not accept those people into the service because of their needs, but also their needs are so great that they need to work towards that point if they so desire that. We have about, just in conclusion, I know we're short for time, but we have about 350, and I know that was part of the submission, in terms of referrals on to other services. The majority of them are for housing and, you know, housing first and engaging people with services that are very basic needs. So I think that this is a service that allows us to reach in and meet people's basic needs and then help them to move on in their recovery journey.
Yeah, and Convener, if I may just ask another short question.
Brief questions and brief responses. I've still got quite a number of members looking to come in.
So I think it's just about understanding that journey. If somebody chooses to seek a path to residential rehabilitation, I suppose it's understanding how you would help to feed into services such as stabilisation to absolutely allow that person the journey towards entering into resi rehab. Because I think a lot of people don't understand that you can't just walk into or get referred straight away into it, because if you are using a high volume of usage, it's very difficult to actually go straight to rehab. So maybe a tiny bit about stabilisation.
Of course, yes, and I suppose that, so we have a range of services in the city. The Thistle is part of our overall alcohol and drug recovery services, which means that access to and referral pathways are the same for the Thistle staff as they are for any part of our alcohol and drug recovery services. We have very clear pathways into all of those services. So whether that be our crisis or residential crisis services, whether it's our residential stabilisation services, or indeed whether it's our residential rehabilitation services. And we have been very clear from the outset. So you may have a circumstance where somebody, for example, has relapsed into injecting behaviours, you know, in terms of their drug use, but has quite a lot of recovery capital behind them, and they might very quickly be able to access residential rehab, and we would absolutely access that and make those referrals. But the majority of people coming into our service are not at a stage where residential, it's comparing apples and pears. They're not at a stage where an abstinence-based residential, and that's what we need to think about when we talk about residential rehab, it's abstinence-based. And people are not at a stage where they can be abstinence-based, either for their own safety, because they require detox, or for the safety, indeed, of other people who are using those services. So I suppose, in summary, pathways are available, but we need to be clear that this is about individuals' needs, rather than you know, an overview that residential is suitable for everybody.
Thank you. I know Sackett wants to come in, but I'm going to hand back to the convener.
I will bring you in if there is time, just towards the end. Thank you. OK, thank you. Annie Wells and then Michael Mara.
Thank you, convener, and apologies I couldn't be there in person today. Just listening to your last response to Eleanor Whittam, I was just wondering, like, I understand that the pathway for everyone is totally different and everyone has their own recovery pathway. But just a quick question, how many people over the 4,000 episodes that have happened within the Thistle Centre, how many people have actually went on to a recovery rehabilitation pathway? And I get it, it's different for everyone, but I'm just asking this one specific question. And that's Kelda, sorry.
Thank you, and again, thank you for the question. So we haven't referred anybody directly from the Thistle into an abstinence-based residential rehabilitation service. And again, I would just go back to that point about it, you know, abstinence-based, and I know I'm overemphasising that, I understand that. But we would not expect. So I think, going back to one of the very earlier questions in terms of have we met our expectations, that was never one of the expectations that we would have set out. It's not one of the... But that would be the same whether that was the individual accessing, you know, any harm reduction service at the point the individuals are. What I would say is it's absolutely available. It is much more likely that we refer into. So, for example, we've had, and you'll see that from the returns, I think over 50 referrals into some kind of care and treatment service. And that's what we would expect to see, whether that's through the enhanced drug treatment service, whether that's through the community teams, or whether that's into crisis and or stabilisation services.
Yeah, and thanks very much for that answer, and I get that. But when we discussed the sort of a pilot for this, we were sort of told that this would be a pathway for people to get into residential rehab, and we aren't really seeing that, although the Scottish Government have increased the number of residential rehab places fourfold in the last year. And it's like, for me, I know Carlton very well. I've got family down there. I went to school down there. I know the place well. And it's just, for me, it's like, yes, I appreciate we can give them a place to go and get them a shower and all that. But for me, it's like when I backed the pilot, I was kind of backing it to see that more people get into residential rehab as well and give them that opportunity. Because when I speak to families of people who have lost their life, my family included, they just wanted help and support and for their family to be looked after and put in, or given the support to go into residential rehab if they wanted it. And that kind of, just for me, it seems a lost opportunity. And I'll leave it there just now with that one, because I do think that we could do so much more there. And the only further one question, a small question, convener. Does the facility offer transport to people to come to the centre? Is there a transport offer there for people to come to the Thistle?
Very brief answer, if possible.
Could I very briefly just comment on the previous comments, because I feel I would have to. So
yeah.
I suppose what I would say is I understand the position. I absolutely do not think it's a lost opportunity, because I think what we're doing is keeping people alive, and quite simply, you can't get people into recovery if they're not alive. And that's, you know, and I know that's a very simplistic point, but it's a point that I think needs to be made. And we are 7 months in, so a year in, you know, 18 months in, we may see more people into, you know, a recovery journey. But I go back to that, the answer that I gave previously about that recovery journey. Recovery is not about residential, abstinence-based residential rehabilitation. Recovery is, for me, improved health and well-being, using less, you know, harmful drugs, using drugs in a less harmful way, and that's, you know, that's the harm reduction to get to a point of recovery. In terms of, very quickly, the answer to the question about transport is no, we don't transport people in as a normal part of the service. We don't have a budget for transporting people to the service. I'm aware that there's been discussions at the Community Engagement Forum and or the Service User Forum about supporting people to access the service through bus tokens, etc. But again, they're conversations that happen in every part of our service, so we don't do anything that is not in line with other services.
OK, thank you. I'm going to bring in
Thank you, convener. Thank you very much.
Michael Mara and then Claire Haughey.
Thank you, Convener. Dr Priyadarshi, can I take you back to some of the comments you made earlier about medical emergencies? You mentioned that there was a spike, I think, probably when the nitazines were in the supply. I think on the figures that we have, that looks like March and April 2025. Would that be correct?
That's correct.
Okay.
Yeah.
And you also said that you felt there had been a decline in medical emergencies of late. I think you referenced the issue around the shift into cocaine. Yep. Is that something you can maybe set out in a little bit more detail for us as to why that would be the case?
Yep. So we're vigilant about medical emergencies for every injecting episode, so we can't be complacent about them at all. The number of medical emergencies does seem to be linked to the amount of heroin. That's a percentage of the injecting episodes within the service. And those individuals who are injecting cocaine, they don't experience the same medical emergencies in terms of what we define medical emergencies are respiratory problems. People stop breathing, the oxygen saturation is reduced significantly, and they require airway management and oxygen at least. For people who use cocaine, the toxicity of cocaine is not doesn't present in the same way. And we haven't actually seen medical emergencies linked to cocaine use. We do see escalating stimulant effects, toxicity. That's how that translates into behaviors. It translates into perhaps people becoming almost sort of having paranoid or psychotic thoughts, and it's about de-escalating those presentations rather than dealing with a cardiac or respiratory arrest.
Okay, that's very useful. It tallies with the evidence I've received from people in Dundee, clinicians as well, that an increase in chaotic and sometimes violent behaviour amongst the drug user community, but potentially decline in emergencies. Taking that up to a kind of a national level, do you think that that shift in the usage could be tied to the reduction in the number of deaths?
It's a really good question, and you're asking me to speculate on that. The first point I would make is around the cocaine, stimulant use and violence. We see very little of really difficult, challenging behaviour that we can't manage and de-escalate quite quickly in-house. I just want to make that point clear. And we've had very few, if any, incidents related to those that we couldn't manage. Yep, so the change in trends may be at least partially explaining the change in the drug death statistics. But the drug death statistics will be the result of many issues. It's multifactorial, and I think any reductions will have different influences. It'll be multifactorial as well. I think the large spikes we saw from 2015, 16, 17 onwards, the amount of benzodiazepines along with opiates was for me a key driver in that. And we've seen in recent years, in the last few years, a reduction in the number of implicated cases with heroin and benzodiazepines. But on the other hand, we've seen a rise in number of cases implicated with cocaine in them. So, and the numbers, although there was a 10% national reduction, there's still more than 1,000 drug-related deaths. So there have been a whole range of other actions and interventions. So in Glasgow City, we saw a 25% reduction in drug-related deaths in 2024. Some of that might be the result of trends, drug-using trends, but we've also implemented a whole range of responses, MAT standards, crisis outreach services. Naloxone coverage is very high. We get radar reports now on almost all overdoses that happen in the city, and we can see that people are carrying and using naloxone. So without naloxone, the death rates would have been much higher as well. So I think that there's a range of reasons to explain the reductions that we've seen.
Thank you very much. Okay, I'm going to bring in Claire Haughey and then Patrick Harvey.
Thank you very much, Convener, and good morning to the panel. You'll be aware that there are calls and indeed campaigns for facilities similar to the Thistle to be opened in other parts of the country. And I would be interested to hear what lessons you've learned. I know you're only 9 months in, but in terms of opening such a facility and what you would do differently.
Okay, I'm going to start with that. I'm sorry I'm doing so much of the talking.
Response as brief as possible.
Okay, so just absolutely that we've learned a lot and we're happy to share our learning, and we've had visits from cities across the United Kingdom to the service. First is around community engagement. I think we need to start community engagement much earlier and need to explain the potential community benefits to the community rather than the focus that we started with, which was the business case around harm reduction and recovery for people who use the service. And that's, I'm sorry to put it as bluntly as that, but I think if we were doing it again, our focus would be what's in it for you and how can we make this work for you. Second would be we get feedback from service users and some of the barriers that we know about that stop people being able to use the service to the extent that we want them to use the service is the absence of smoking or inhalation space within the service. So we've seen the drug trends that I've described, but also some people will smoke and inject in one episode of drug use. And if we can't split those, so if we can't offer the smoking inhalation space, they won't come into the service just for the injecting itself. The other few barriers are ones that have got sort of more challenging legal situations around them. So sharing is an issue for people. Yeah. So drugs people often buy in small groups and buy a significant amount of drugs because by pooling your resources together, you can purchase more that will last you more through the day, for example, with cocaine injecting. But we can't allow the sharing of that within the facility. And so if other areas were to come on board, we might want to have a national discussion with legal authorities on that. The women's, we've got a lot of learning around access for women as well. We haven't solved that, but perhaps other things that other areas could do earlier. And just to keep this as brief, those are, if you like, the top headlines. But the biggest headline of all is that I think we've demonstrated that we're able to deliver what was seen as a very high-risk, very controversial service. It's able to delivered within statutory services by in a safe and effective manner to date.
Thank you. Thank you, Convener.
Okay. Thank you, Claire. And finally, Patrick Harvey.
Thank you, Convener, and thank you to all the witnesses for their evidence. I'm keen to just understand a little more about the balance between the fairly clear evidence about the benefits of people who might have an adverse reaction or an emergency in a safer environment, the benefits in terms of reduced drug paraphernalia in the local community, compared with the concerns that have been expressed about there being more unknown faces around, whether that's service users or potentially dealers. I couldn't see anything in the written submissions that tells me whether you collect information about where people are travelling from, where your service users are travelling from. It may not be easy to get objective data, but do you have a sense at all of whether people are travelling across the city or even from further afield, or are you overwhelmingly looking at people who would otherwise be using in another environment in the Calton area?
Yeah, so we do collect some data on home postcodes, but they're to do with where people have used injecting equipment provision in the past. Mm-hmm. So, and that data is not accurate because it may be very historical rather than present. So I think that question is challenging to answer robustly, but what we know from the evidence that we've collected in the past, that the population we're talking about, the majority of them are people who are resident in and around the city centre and the East End of the city, either in their own accommodation, temporary furnished accommodations, hostels, or in homeless settings in there. They consume, the key issue is where the drug market is. So they buy their drugs and they consume their drugs very close to where the drug market is, because they do not want to travel with drugs on them. There are people who come into the city centre and into the East End of the city centre to access that drug market and then use their drugs closely, and that's been a historic thing. We've been doing outreach there for 10, 15 years and have that evidence. And that group isn't local, but they're not coming in to use the Thistle. They're coming in primarily for the drug market and to purchase their drugs. And if they didn't use the Thistle, they would be using the outdoor spaces.
Okay, thank you very much.
Thank you very much. Did you want a very, very quick?
Yeah, I was just reflecting on some of the. Thank you, Convener. I was just reflecting very quickly on some of the opportunities for improvement of the service, and I've noted, particularly in Boston and New York, there is a community syringe redemption programme that's been launched in the last 5 years, and whether this is something that has been considered as an evolution of the service, particularly given the significant benefits that have been demonstrated from the small cash incentive to return syringes.
Yes, thank you. Now, I will be very brief in the answer, because, again, that was one of, I think that was reported at some point. We certainly received an inquiry about that. So it was an issue that was discussed at the Community Engagement Forum. Very briefly, there was definitely no decision to move forward with that as a proposal. And, in fact, without getting into the detail, there's actually some, we would have some concerns and some challenges associated with that. So I suppose what I would say is we are always looking at ways to improve the community and improve engagement with the community. And in fact, people who are using the service and our recovery communities are clear that they want to be involved without financial remuneration, I would have to say, but want to be involved with the environment and the community, and that giving back to the community that you will hear people talking about, so particularly recovery communities. So that's the model that we're looking at, Paul.
If I can just add very quickly, just as well as, thinking about whether we need to expand the bins, the injecting bins, and work with our councils around sort of increased frequency of cleanups. I know you were going to give me potentially one last. I just want to make one very quick comment around access to services through this Thistle. It's just a very basic point that actually our staff are walking a fine line between wanting to give people support to access the whole system of care and not overwhelm people who are already feeling, quite worried about using the service. So they have to take time to build relationships and work in a very person-centred way. So you'll see that the data that we have around our interventions and our referrals don't reflect what we think is best for people, but actually is what people are asking for.
Thank you very much. Okay, apologies for having to rush the session. We've got limited time and a lot to cover. So thank you very much for your forbearance, and thank you for coming along today. So we'll just briefly suspend the meeting to allow a changeover. Thank you very much again. second panel this morning, and I welcome Marie Todd, MSP, Minister for Drugs and Alcohol Policy and Sport, and I believe this is your first appearance at a cross-committee meeting, so you're very welcome, Minister. We've also got Maggie Page, Unit Head of Drug Strategy with the Scottish Government, and Dr Tara Shivaji, Consultant in Public Health Medicine, Drugs, Alcohol, Public Health Scotland. So welcome to you all. So can I first of all invite the Minister to make some opening remarks? Minister.
Thank you very much for the opportunity to appear before committee today. I look forward to updating you on the vital work underway to address the harms and deaths caused by alcohol and drugs. Since the last cross-committee session in February, updated statistics have been published by the National Record Scotland. In 2024, there were 1,017 drug misuse deaths registered in Scotland. That's a decrease of 13% compared to 2023. It's also important to note that alcohol-specific death statistics saw a 7% decrease in deaths to 1,185. That's the lowest number since 2019. Now, let me be absolutely clear, whilst it's welcome that both these statistics show a decline, the figures are still far too high. We know from recent surveillance that there are new threats and there are the drug-related harms in Scotland are still high. Every death is a profound tragedy and every death is one too many. Crucially, every death is preventable. So we must use every tool available to address this crisis, and in that spirit I very much welcome the work of this committee and the recommendations of the People's Panel, Audit Scotland and the 2022 Drug Death Task Force report. Collectively, these reports offer 164 recommendations, and I'm reassured by the many common themes and alignment. Our written evidence to the committee details our response and progress against each recommendation and how they've helped to shape our approach to the national mission. Since launching the national mission in 2021, we've taken a range of action. We've made 38 million available between 8 projects across Scotland to provide additional residential rehabilitation beds. We've invested over 4 million in widening access to life-saving naloxone. And we've opened the globally recognised and UK's first safer drug consumption facility in Glasgow. The Thistle has now overseen over 4,000 injecting episodes since opening and responded to over 50 on-site overdose incidents, and I have absolutely no doubt that lives have been saved. These achievements were hard won, and I extend my gratitude to those who made them possible, especially individuals with lived experience. I'd like to highlight some of the key progress since last committee session. We're helping to build a skilled and resilient workforce through the publication of new guiding principles and 2 employability toolkits. We're also seeing good progress in MAT implementation. The June benchmarking report indicated that 91% of MAT standards 1 to 5 were assessed as fully implemented, and 75% of standards 6 to 10 were assessed as fully implemented. We've also seen progress in residential rehab, and August saw the official opening of the new Crossreach facility in Inverness. That's the latest of 8 new or extended facilities supported through our funding of 38 million. But I do recognise we need to go further, and I've heard the calls for further and faster action. We're developing now a refreshed alcohol and drug strategic plan, consulting key stakeholders, including people with lived and living experience. After 5 years of emergency response to the drug death crisis, it is time to build on our progress, to move to a model of sustainability and to embed long-term change. We're committed to change, driven by the belief that progress is both necessary and possible, and I welcome your questions and look forward to discussing these findings further. Thank you.
Thank you. Thank you very much, Minister. So I'm just going to move quickly into my first question, just with regard to the sort of work of the national mission. So we know you spoke about figures in and around drug deaths, and we know that there was a 13% decrease in drug deaths from 2023 to 24. However, Police Scotland data showed that there was a 3% increase in the number of suspected drug deaths in the first months of 2025 compared to the same period in 2024. So I'm just wonder if you can maybe respond in a wee bit more detail to these figures and what they mean in the context of the work within the national mission.
I think Tara may want to come in on this, but I'll certainly give a first response. So, I mean, I really welcome that decrease, and I think all of us will welcome that decrease. It's substantial, and we are very pleased to see it. But you've heard from, in this evidence session, from other witnesses who were on before us, just about the changing market that's out there and the differences in the way that people are taking drugs. That's bringing new threats, which indicates to me that we need to be agile about how we respond to these harms. So when we started the national mission back in 2020, largely we were dealing with injecting of opioids, injecting of heroin. Now in 2025, we have a significantly increased threat from injecting cocaine, which is, your medical witness described, requires many more frequent injecting episodes, real risk from injection harm. The market is undoubtedly contaminated. So the bulk of, mostly what people are buying in Scotland, what they think they are buying is not what they are getting. Mm-hmm. So we've seen a recent spike in harm in Glasgow caused by cocaine contaminated with synthetic cannabinoids. We've seen heroin contaminated with nitocines. And that is causing real challenges for how we respond to the situation. We've seen a difference in the way that people are taking their drugs. So as well as the increase in injecting episodes from cocaine, we're seeing more smoking than we have before, more inhalation routes. So that we just need to remain agile. Things are not static. And I think we have brilliant systems in place now to understand what is happening out there and to quickly learn where the harms are coming from and get good, high-quality information out across the country. But it's a challenging situation to stay ahead of quite a dynamic situation that's out there. So I think Tara will want to say more about radar and how we pick up on. Mm-hmm.
Yes, so I think the figures that again, we would welcome the reduction in drug-related deaths, but taking a more longer-term view, actually, what we would say is that it appears that figures are plateauing rather than we're on a steady decrease. And what we've seen from our most recent indicators in our radar report is that harms are actually increasing. So in addition to the figures that you've mentioned about drug-related deaths, we've also seen an increase in ambulance call-outs. We attribute this to the instability and toxicity in the market. The way that this has played out this year has been in the early part of this year through quite localised clusters. Now, we don't have the intelligence to understand what was happening in those drug markets, but we know that there are subpopulations of people who were at higher risk. So particularly people who were in temporary or unstable accommodation seem to feature quite a lot in these clusters. I think for us, some of the features, other than the very high toxicity of these new substances that are coming in, is that dynamic pattern. So whilst we focus on individual substances, the reality is that these are multiple substances occurring together. They may not be taken exactly at the same time, but they have these synergistic effects. And contamination is a really big problem in the supply.
Okay, thank you for that. Before I bring in Paul Sweeney, I'm just going to bring in Michael O'Mara with a brief supplementary.
Thanks. Minister, you mentioned the systems for the understanding and data. Could you tell us the current time lag for a forensic toxicology report?
I couldn't tell you that off the top of my head, no.
Okay. Does any officials know how long it takes between death and the production of a toxicology
report? So you're talking about post-mortem toxicology specifically. So I think it's significantly faster for toxicology. For example, Dr. Priyadarshi described the situation that occurred at the Thistle where some of the paraphernalia was tested. That's pretty rapid. Yeah. They were able to get information almost instantaneously. I think there is on occasion delay for post-mortem toxicology. I was asked about that at the Justice Committee last week, and I said I would supply written information in afterwards, and I'll certainly be happy to furnish you with that information if it's specifically post-mortem toxicology that you're asking about.
Yes, it is.
Yep.
So can I identify? So I guess there's a number of steps that happen following someone dying. And the production of post-mortem toxicology across the country, by and large, is about sort of 6 to 8 weeks after the event. But this varies in different places, and it's not necessarily available to local areas at that time, because then it would need to go back to the pathologist for confirmation as to what was the actual cause of death. So there are a number of factors that need to be considered, and there are areas that do have issues around the availability of pathologists to provide that service. What I did want to say was, in the event of clusters, there is a fast-track process that we've put in place, and colleagues within the forensic laboratories are processing these samples faster and able to provide these reports, both for post-mortem toxicology and also for police seizures.
Okay. And we'll see some of that detail in the response from the Minister. That's useful. Thank you.
Okay, Paul Sweeney and then Eleanor Whittam.
Thank you, Convener. So, Minister, obviously you heard the contributions from the previous panel. Just wondered if you might want to outline the government's view on how the current overdose prevention pilot at the Thistle is currently performing after several months of operation now, in the awareness of the recent metrics.
As I said in my opening statement, I am confident that lives have been saved in that unit. I visited in June, and of course at the moment it's anecdotal evidence. They're collecting data. This is being well analysed by excellent academics in Scotland, and I think as time goes on we will get better understanding of the work that's going on at the Thistle. But the staff I spoke to were very clear with me that that cluster of overdose incidents in March, April, that undoubtedly, had those people not been using in the Thistle, they would have died, and we saw across Scotland other people taking similar drugs and dying. So I think the first thing to say is that I'm absolutely confident that it's saving lives. There is no doubt that there is concern in the community. I was pleased to hear from the witnesses today that some of these concerns are being allayed as they are working along with the people running the Thistle in order to tackle the concerns of the community and of the businesses around it. And certainly I was pleased to hear about the holistic approach they are taking and person-centred approach they are taking to the individuals who are coming through the door. There isn't a set path for these people. They meet them where they are, encourage them in, and help to find them, for example, accommodation, which can for many people be the very first step on the road to recovery.
Just wondered if also the Minister had heard some of the suggestions for enhancement of the service. Obviously there was discussion around the change in drug injection types and frequency, opening hours, but also the issue of inhalation, particularly with crack cocaine. I'm aware there is a paper at the Integration Joint Board in Glasgow about an inhalation service, and whether your office minister is considering how you might be able to assist in expediting that.
So we work alongside the individuals from the Thistle and Maggie Mee want to come in on this. We work closely with the organisations running the Thistle, but largely it is down to them to work with the Lord Advocate to meet criteria that she may set to ensure that the conditions within the unit can change. So it's a long process to get those permissions and to persuade that the legislation that covers the rest of the country can be lifted under certain circumstances. I know that the Scottish Affairs Committee down in Westminster reported recently on the Thistle and made some suggestions for different models. The challenge with that is that we have not been able to persuade the Westminster Government to review the Misuse of Drugs Act, and because that has not happened, what's happening at the Thistle is happening in a one-off situation, and each time the model is modified, that will have to be agreed locally with the Lord Advocate. So that means it's difficult, and very, very careful steps must be taken to make any changes to the model that operates there. I don't know, Maggie, if you want to say more.
I mean, I think just to add that, yes, this would be a decision for local areas to work with Lord Advocate, but officials would be supporting Glasgow and any other areas where appropriate.
Just wonder if you had any wider comments on the Scottish Affairs Committee recommendations, just given it was referenced by the Minister there.
I mean, I think things like they made a suggestion around mobile units being more cost effective, and certainly I can think of certain areas where that might meet the pattern of need better than a fixed unit. But the challenge is that with the Misuse of Drugs Act in place as it is, and the conditions that have been put forward by the Lord Advocate, that means that the model of a safer drug consumption unit is not scalable and not sustainable. We really need the legislation to change, and I think it's reasonable to ask for it to be reviewed. This legislation is over 50 years old. It's older than I am, and I'm a granny. It doesn't, I don't think it's fit for modern purposes. I don't think it's fit for the threats and harms that we are facing as a population today. So I think it's reasonable for us to consider looking at modifying that piece of legislation to see whether it can be made more effective and particularly enable us to better take a public health harm reduction approach.
Just to add to that, we have responded in writing to the committee, which I think probably has arrived today, just against all of the conclusions and recommendations of that Scottish Affairs Committee report. And one of the other key things which was in there is around provision of crack pipes in response to that rising use of cocaine and the harms associated with that. And that's another thing that is restricted under the Misuse of Drugs Act at the moment. So not just within inhalation spaces, within the drug consumption facility, but provision of crack pipes as well.
Okay. Just wondered if you mentioned you needed to engage with ministers and other governments, devolved and UK government, whether you've been able to have those conversations in recent weeks? Yeah,
just within, was it a couple of weeks ago? Yeah, we had a UK Four Nations meeting here in Edinburgh, which was very helpful. I suppose it was very clear to me by the end of that day. It was very helpful to meet with my UK counterparts, but it's very clear to me that we are facing a very different challenge in Scotland. We have significant drugs deaths, and we need to take action to tackle the drugs deaths. That's not particularly the situation that they're experiencing in Northern Ireland or in England. And they're not feeling the urgency to look at creative solutions to the challenges that they're facing. That week was the week of the reshuffle in government, so all of the Home Office ministers had changed and none of them came to Edinburgh. So I think we've written subsequently or are writing subsequently with specific requests. Certainly I spoke to the Home Office on the day officials about requesting to the Minister, were they willing to look at this question around inhalation pipes and harm reduction opportunities in terms of providing paraphernalia to people who are using drugs, and if they aren't, then we will have clarity that we need to pursue solutions for Scotland alone.
Okay, Eleanor Whittam and then Alexander Stewart.
Thanks very much, Convener. You've already touched on the question I had round about the last quarterly radar report. And I was wondering if you could just perhaps set out just why those reports are so important in terms of the information that is given us in the last report about the increases in naloxone administration, A&E attendances, and you've spoke to why that's perhaps happening in terms of the toxicity of the supply. And I do anticipate that we might see in the next quarterly report other incidences of that type of increased emergency response. But with regards to, I guess, WEDINOS information, assist information that we get from, toxicology and the hospital reports, etc., why exactly is radar just so important for us as a tool?
Yeah, I'll let Tara come in, but I think radar is giving us rapid information which is able to be disseminated out to exactly where it's needed across the country, and it is making a difference in the harms experienced across Scotland. It's not perfect, so my sense a few months into this job is that the longer they take to produce the data, the more rich and robust it is. So we get early data that tells us something. Often the longer we wait for the data, the richer it is. But we haven't got time to wait. We're in a drugs death crisis, and we need fast information, and that fast information out to the front line, out to the health boards, out to where people are likely to go to receive treatment for overdoses, out to right into the front line so that the paramedics know what they're dealing with, so that the alcohol and drug services know what they're dealing with, I think is really, really vitally important.
So if I could just add, we've got 3 objectives in radar. One is identifying and describing trends. The second is identifying new and emergent drugs and being able to provide a bit of description about, are they important? Are they ones that we should be concerned about? And the third is about identifying and responding to clusters. So although the reports are perhaps the most visible part of it, we have a system that sits behind it where local areas in particular have built both the intelligence that comes into us, but also those response structures. So if I take us back to 2015, when Itizolam came onto the market, it took us 3-4 years to actually understand that Itizolam was a problem and the scale at which Itizolam was causing harm. So our focus here is to be able to identify what are these new substances, provide quite clear, consistent information about them. So we've recently issued an alert for nitazines that we've updated. We're able to give information about where do we find it, what does it look like, and what are the key harm reduction measures. And that's the sort of critical information that staff need. In terms of the sort of trends, that they're probably interesting, but less useful in terms of service planning, but they give people a heads up to say, is there something unusual happening here? And that's particularly important when we're talking about clusters, because we've also developed guidance to allow a public health response to these emergent situations. So rather than, again, retrospectively saying we had a peak, we were able to say we're in the middle of something quite unusual, let's take a much more proactive response.
Thank you. And my second question was round about, obviously given the toxicity of the supply that's out there, people's access to crisis and stabilisation services are quite important. So it was perhaps an update on the stabilisation fund, how that's been deployed in areas, whether areas are working together to create facilities to actually address that need, and whether those facilities are mindful of the increased use of stimulants and obviously the benzodiazepines that are being used as well. And that's a very different type of stabilisation services that are needed.
Thanks very much. Yeah, really excellent question. So I would say I think Maggie will want to come in with a little bit more detail, but we think about 3 strands when we're thinking about the next steps and around treatment and access to residential rehab. One, we've focused very much on providing funded places, and we're on track to reach the 1,000 funded places that we committed to. We focused on increasing capacity of residential rehab, and we have, really improved the number of, we've really increased the number of beds available. I think we get a report on that next November. Perhaps that report comes out and where we're at. But again, substantial increase. The bit that I think probably requires a bit more focus in our strategy next year is around the pathways around access to residential rehab, so the access to stabilisation, access to detox. How do we get things lined up so that people, I think, again, your previous panel talked about, access to abstinence-based residential rehab, then often people require to go through a medical detoxification before they can do that. It would be ideal if the residential rehab lined up right at the end of the detox and there wasn't a gap, or there wasn't a long wait for detox when somebody is ready for residential rehab and wants to get in. So we're working very hard on those pathways to improve the access into services because we think that's an area where we can see real improvement.
I think just to add to that, I think there's a lot of work still to be done around looking at stabilisation and crisis care more generally in terms of both residential and in community settings, and that's part of the priorities and what's coming through from our consultation around post-26 and post-national mission. But we're also looking to publish a national service specification which was sort of set out for local areas, what the sort of component parts of a treatment system should look like in local areas, but that being adaptable to the different needs of different areas. Obviously, what Glasgow has and what Shetland has to be adaptable to those to the context. But yeah, so that is another area of work that we're looking at.
I think that's quite helpful for us to know, just because the fact that 3 million stabilisation fund seems to be very difficult to get out the gates, and perhaps having that service specification will help areas to start to work together to figure out what they need to provide locally. So thanks for that update.
Thank you. Okay, Alexander Stewart and then Sharon Dowie.
Thank you, Minister. Back in September, you spoke about, in the statement you did then, about trying to publish the next phase of the mission statement, and that it was your plan to ensure that there was enough funding to deliver that next phase. So it would be good to get a sense from you about how you see that progressing and ensuring that you don't lose any momentum in managing the national mission work as it progresses.
So the time period that the national mission covers comes to an end in 2026, and we are keen to set out early next year, so before Parliament dissolves, a national drug and alcohol strategy, which we would see as the next phase. There will be some significant changes in that. Firstly, that we're looking at drugs and alcohol together. They require different approaches, but we will be looking at them in one strategy for a number of reasons. In terms of the funding, I think I would like to hope there'll be some clarity in the budget process this year. I can't preempt the budget process, but obviously the budget process sits alongside the strategy. I think my personal view is now is not the time to be cutting funding to these services, so I'm pretty keen to offer assurance that what comes next is unlikely to be smaller.
Okay. Thank you.
Okay, thank you very much. Sharon Dowie and then Patrick Carvey.
Thank you. Good morning. There are a significant number of reports, strategies and policies in this area, and you mentioned a few of them in your opening remarks, but we also regularly hear that there is an implementation gap in areas where there's been lack of progress. For example, the Auditor General for Scotland raised this with the Public Audit Committee in November last year. So do you agree there is an issue with implementation, and what plans do the Scottish Government have to address this?
So I do agree there's an issue with implementation. I think that's one of the challenges that all ministers face in all portfolio areas at all times. We have often set out great ideas. We very often produce fantastic policies and great legislation, but that's not how it feels on the ground for people accessing our services. And one of the challenges as a minister is to close that gap so that the reality meets the ambition. So I would be the first to acknowledge that there is a gap. I think for me as a minister, one of the crucial things to closing that gap is the involvement of lived experience. And if we have lived experience and living experience voices at the heart of our policy and legislative development, it keeps us right. It means that we are usually on the right track because we're listening to the right people. It also holds our feet to the fire on delivery. So that helps us to close the implementation gap. And this government is very keen. I mean, it's always evolving. Nobody's saying we get it 100% right. And of course, lived experience, and particularly in this area where there's a huge amount of passion, lived experience don't speak with one voice. But I think that helps us to get it right. We have lots and lots of data that comes in, lots of monitoring, supervision. In fact, some people feel quite overburdened by the reporting that we request from them. But we are pretty keen to understand what is going on out there. And my sense is that we are very much aware of the challenges and providing support where we can so that local areas can rise and meet them. I don't know if there's anything more you want to say?
I mean, I think just to add that there is obviously ongoing work around implementation with the MAT standards. We continue to support the MAT standards implementation support team, which is MIST, which is housed within Public Health Scotland. So the latest benchmarking report shows progress towards implementation, but that work is continuing. And it is about working really closely with partners at both national and local level.
So I'm just wondering if you can tell us a bit more about what the barriers would be, because even in your evidence to the Criminal Justice Committee last week, it's evident you want things to happen on the ground, and you did say last week that you thought there were implementation gaps as well. So you've got great policies, you want things to happen, but it's not. So are we holding those officials accountable enough for the people that should be making sure that this happens? You said earlier, we haven't got time to wait, we're in a drug death crisis. You said about holding your feet to the fire. We've got lots and lots of data. And I think for me being in a committee, I suddenly sigh when I hear that we're going to have another working group and another working group looking at something that we already have the answer to. We know what the issues are. So what are the barriers to actually implementing it so that we see the difference on the ground?
So I think there are a number of barriers, and I think that's the challenge with this whole issue. And I think you'll be very well aware, having been involved for a number of years, just how complex the subject is and how difficult. I think stigma is a big issue. So there's lots of reasons why services are set up in a way that mean that people struggle to cross the door even to access them. There isn't, I don't think, a simple answer. I think if there were a simple answer to fixing this problem, we'd have done it. All of us would have pushed to have that done. I don't think there's any simple, straightforward way around it. We just have to work hard to understand what's happening out there. We have to look in each local area as to what the barriers are there, what the challenges are. We've heard about some of the challenges of women accessing services. We need to understand why certain cohorts find it difficult to access the services that we provide, and we need to make it easier for them to do that. I think the Charter of Rights will help us to make progress in this area, because I do think stigma is a big part of the problem, a big part of the reason. I think that stops people every day from accessing help. So I think we've got a lot to do, but I don't think there's a simple answer, Sharon. If there were, we'd have done it.
Okay, Maggie, have you got anything else to add? No.
Well, I would just add as well, I think obviously workforce is always a challenge, I think, across health and social care, and there's been a lot of work happening in order to support the workforce in terms of upskilling the workforce, encouraging people who've lived and living experience and who are in recovery to become part of the workforce, have a really vital role to play as well. So there is work around that, but I think that is another significant challenge.
Okay, thanks.
Thank you. Patrick Harvey and Pauline McNeill.
Thank you, Convener. Good morning. I wanted to press you a little further on the issues that Paul Sweeney raised about the Thistle and more generally about the way you see the future of safer drug consumption facilities. We acknowledge that it's early days for the Thistle, so let's acknowledge that a full evaluation is to come, but let's ask you to assume that it evaluates well. And you also, I think, push back a little bit about the issues around the legislation, reserved legislation, which, for the life of me, I can't understand why we didn't devolve that in 2016 when we addressed other irrational reservations in the Scotland Act on a consensual cross-party basis. I wish that we were able to do that. But let's ask you to assume as well that the government is going to be successful at making the case either to change or to devolve the legislation on that, and that those legal barriers can be removed. You presumably have some idea in your head already about what level of provision of this type of facility there ought to be in order to address the needs not just of one community but of multiple communities around Scotland. Do you have a sense of how extensive a network of this type of facility a city like Glasgow ought to have, or that the country of Scotland ought to have, if those legal barriers were removed and if the evaluation of the early phase proves to be positive?
So that's a really good question. I mean, I don't have a sense of where we would be if there were no barriers. What I do have is a sense of where the need might arise and where local stakeholders are already looking into it. So I think if you look at a map of Scotland, you can see quite easily where most, where there are concentrations of drug deaths, and those would seem sensible places to consider a facility like that to me. At the moment, we have work coming forward from Edinburgh and at a very earlier stage from Dundee considering safer drug consumption facilities. And I think given the number of deaths that occur in both those localities, it is reasonable. Edinburgh is a little more advanced, and the two sites that they've identified, which seem like reasonable, they do appear to have matched up the potential sites with where the deaths are occurring. So for one of them, in the last 3 years, there's been 34 deaths within a 15-minute walk. For the other site that they're considering, there's been 36 deaths in the last 3 years within a 15-minute walk. I think it's really important that local areas look at what is happening in their locality. I mean, earlier this week I met with partners in Inverclyde, and drug use and drug deaths are significantly more scattered in that part of the country, very high on the national statistics.
Yeah.
Clearly, creative thought needs to go into how to rise and meet that challenge, but actually a fixed drug consumption room may not be the appropriate solution for that locality because drugs deaths are happening right throughout it.
I mean, I absolutely take the point about the connection to drug deaths and to places where there's a particular cluster, albeit that may change over time as well, where those clusters occur and how those patterns change. But some of the evidence that we heard earlier and that we've got in the written submissions as well shows that that's not actually the only benefit. The reduction in drug paraphernalia in communities, the reduction in people being exposed to drug taking in communities, in other settings, that seems quite clear that there's a significant benefit. And there could be the opportunity to achieve those benefits in other parts of communities that may not have the same cluster of deaths at a particular time to justify a fixed facility. So I'm just curious to see if there's a sense within government or within the public health community in Scotland more generally of where this could go if the barriers were removed.
Yeah, I mean, I think I would say we haven't explored that because the barriers are not being removed, and we have been unsuccessful thus far in removing the barriers. If you remember rightly, the efforts to bring the Thistle to life started in 2015, I think it was. So that's 10 years ago. It opened this year. They started that was predates the national mission at the very start of the rise in drugs deaths, but the reasoning behind considering a safer drug consumption facility at that time was to reduce HIV, because there had been an outbreak, a cluster of HIV in the area, and it was seen as a way of reducing that harm. So I think you're right. There's, at the moment, and I suppose we're in the thick of a drugs death emergency, and we have very early data that showed that lives have definitely been saved at that unit. So it's understandable that we are recognising it's a life-saving facility. It definitely prevents deaths. There are definitely, I would say, we'll have a more thorough evaluation of what happens there and what the benefits and disbenefits are, and we will consider where to go when we have a bit more information. At the moment, I'm not seeing those barriers to scale ability across Scotland and even sustainability being removed. I sense, we had a change of government last year. I thought there would be an opportunity for a change in approach. I'm not sensing that at all. And I have to focus on the here and now. I have to focus on the emergency that we're in and find a way forward now.
Have the new UK ministers that you mentioned shown an interest in visiting the facility and seeing for themselves what's happening?
Well, the Home Office Minister, so my equivalent is actually a Justice Minister in the UK, although the Public Health Minister did also attend the UK four-nation meeting. They were brand new that week, so I don't think they'll have had a chance to visit the Thistle yet, but yes, I would certainly commend that to them.
Thank you very much.
My visit, I found, I worked in a hospital for 20 years, so I'm used to a clinical environment, and I worked in a mental health hospital, so I'm used to working with people who are often stigmatised and on the edge of society. I was hugely impressed by the facility. I was impressed by the professionalism of the staff, by the warm welcome, by the thoroughness of the work that goes on there. And I have absolutely no doubt that it is life-saving.
Thank you very much.
Okay, thank you. I think, Annie Wells, you've got a very brief supplementary to this point. If you can come in, and then I'll bring in Pauline McNeill.
Sorry, Convener, it's not really to this point, so I'll wait till the end if you don't mind.
Okay, thank you. Okay, I'll bring in Pauline McNeill and then Michael Mara.
Thank you. Good morning. I do agree, Minister, it's a very impressive set-up, very professional. And one of the things that I noted was the referral services. And I think that's really important. And I wanted to ask you about longer-term approaches. So I wanted to start by saying, you've heard, in fact, it was Annie Wells that asked the question about had there been any referrals to rehabilitation yet, but it's early days. So the focus is on getting the service up and running. But, Minister, would you hope that at some point fairly soon we'll begin to see that, because obviously it's about saving lives, but you need to try and get people off the thing that's putting them at risk in the first place. Are you hopeful that we'll get to see more referrals for rehabilitation out of this?
So I think we need to be very careful about setting expectations around that. This service is life-saving, as we've heard, and I thought the point that was made by the earlier panel member, I think it might have been Kelda who said it, that if people aren't alive, they can't be rehabilitated. So the profound importance of saving lives, I think, can't be underestimated. Then we need to think about recovery journey and first steps on recovery journey and how we achieve person-centred, individualised recovery. Now, I'm pretty clear that abstinence is not recovery. We shouldn't mistake the two things. Recovery is often the first step on recovery, on that recovery journey, is stabilising housing, having a secure roof over your head. We've heard from Tara just how significantly at risk people are if they have unstable housing. They're at significantly higher risk of death. So I'm concerned about the narrative that suggests that that high rate of referral from housing might not be a success, that the only measure of success, and I know this is not what you're saying, Pauline.
That's not what I'm saying,
no,
not at all.
but that would concern me if we thought the only measure of success was referral into treatment. I think we heard the statistic that over 50 people have been referred onward to treatment, and I think that's reasonable if you think about the first 6 months and if you think about the level of chaos that the people coming through the door are experiencing, to within 6 months having 50 people referred onwards for some form of treatment, not necessarily residential rehab, I think is reasonable.
No, I didn't mean that. And in fact, what you may know, I hosted a meeting in 2016, actually, early on, and supported the... in fact, I hosted the Danish lawyer who had been very successful and brought the idea to Scotland, so I'm fully committed to it. But I'm interested in longer term policy, and I don't know, maybe Tara, maybe it may be appropriate for you to answer this question if you can, because you talked about housing. We know that women don't access services, but I wanted to ask about men, the vulnerabilities in men who are drug users, and whether or not in the policy agenda, looking ahead, to the future, if any thought has been given to, what we need to do longer term to address these questions of the vulnerabilities, particularly in male users, I thought, just because they are the higher number. And I'd be very keen to hear anything you have to say about that.
Yes, happy to, and thank you for the question. I suppose I sort of frame this answer from the learning that we've taken from the National Mission. So Public Health Scotland has been conducting an evaluation of the National Mission, and a lot of our questions are about what's worked for whom in what circumstances, and what needs to improve. And we've tried to feed this in along the way. And I think one of the challenges that people have described has been that ability to work across different areas. So we've talked about housing, but quite often what you will see is quite a lot of work of multidisciplinary teams involving housing, involving justice, social work, working at a local level. But there's a difficulty in implementing measures or working at scale, because there are competing priorities for other departments, and that does limit the ability to work at scale. So I think recognising that we need that wider input beyond the drug and alcohol treatment service is important. Housing would be one area. Justice settings would be another area that is particularly important for men, and how we are approaching people, the quality of care that they're getting, not just drug treatment, but also addressing underlying mental health issues within these settings has been another issue that's been mentioned. And then I think something that we would need to develop much more fully further is our approach to prevention more generally, about how are we preventing people using substances. So I think what we need to do is really think about what are those universal approaches that apply to everybody, who's at more high risk, and how do we address their needs. And the approach that we recently published, a consensus statement where actually a lot of stakeholders are in agreement about what we need to do. We need to work in a very person-centred, relational way with people, and we need to address some of these underlying factors that contribute to vulnerabilities to using problematic substances, be it alcohol, be it drugs, be it tobacco. And to do that, there's a recognition that, again, it's multiple partners, it's that shared accountability across different governance structures that we're all responsible for the same outcomes.
Thank you. Thank you very much.
Yeah, thank you very much. Michael Mara and then Annie Wells.
Thanks, Convener. So you have set out already, Minister, some of the long-term challenges of setting up the Thistle, and we've had some exchanges previously on drug checking centres. I wonder if you could just set out to us where you are with drug checking facilities, particularly in reference to Dundee, and if I can, I'll put on the record, Convener, that I was previously Deputy Director of the Leverhulme Research Centre for Forensic Science at the University.
Yeah, thanks very much. So I think we're at the point where the Home Office have approved a licence for Glasgow, so they are just working hard to deliver that. The other two facilities there are three other proposed facilities, Aberdeen, Dundee and Edinburgh. Edinburgh is a little further behind the other two and came quite late to the pilot. Aberdeen and Dundee are quite developed but require there to be a drug testing facility in Dundee, and the National Testing Reference Laboratory needs to be up and running for those two to be able to finalise their application to the Home Office. I met with Leverhulme last week. I'm confident in the progress and we are supporting as much as we can the process of getting the National Testing and Reference Laboratory up and running. I know you've got a request in to meet with me and I'm very happy to meet with you sometime soon over the next few weeks, and I can update you fully on where we're at, but we're on the cusp of progress there, and I'm pretty sure we're just doing the final touches.
Okay, I appreciate that, and obviously we'll have a more detailed conversation in that meeting, but just to get some on the record today, it has been a long-term project. I understand the challenges in terms of the licensing across the UK, and it's right that we're getting to the point of completion, and hopefully it makes a big difference. On specific to the Dundee one, is there any particular challenges that are arising with the university in getting that progress, or is it, is there a sticking point that you would like to see unpicked in the next couple of weeks that would allow us to see an announcement, perhaps even prior to recess?
So with reference to the National Testing Laboratory at the Leverhulme Centre, I think we've been working quite closely. I mean, the government as a whole has been working very closely with Dundee University since last year and the challenges that they have faced, and providing a great deal of support, including financial. We are pretty close, I think, to resolution on the issues that the Leverhulme was facing with getting the National Testing Laboratory up and running. So I'm confident that there will be, that things are on track there. I don't know, Maggie, is there more you want to say about where we are?
No, I think that's really where we are right now. I mean, just to reiterate, the point of care sites for Edinburgh, for Aberdeen, Dundee and Glasgow have all submitted their licence applications to the Home Office, and they've all had their essential compliance visits. So things are moving and progressing on that front.
The model in Aberdeen and Dundee both require the Dundee lab to be a part of it, though.
That's great. And you'll understand my concern in terms of given the parallel processes going on at the university and the real crisis at the moment, but this is obviously a critical piece of national infrastructure for saving lives, and we want to see it in place. So it's just for me to get assurance that the university isn't holding that process up. I'll maybe put some words down to the principal in that regard anyway, but I'm hopeful to see something in the next couple of weeks.
Yeah, I think that it would be fair to say that the situation that Dundee University as a whole has faced has probably slowed progress slightly over the course of the last year, but we're motoring now.
Great. Thank you so much.
Thank you. Annie Wells.
Thank you, Convener. And just a question for the Minister, probably. We've heard from a man who's lived in the Calton area for 42 years and is a drug addict himself and has been trying to get off drugs for quite a long time. But he said the situation's the worst he's ever seen with drug dealers and that in the area. And he feels he's been left behind. So really the question is, Minister, it's what are you doing in the area to what measure are you putting in to make a difference so that drug dealers aren't coming into the area? And will these efforts make a positive effect on this gentleman's life?
So I'd like to hope that these efforts will make a positive impact on this gentleman's life. We heard from the previous panel about the work that is going on in terms of outreach from the Thistle Centre, and we heard from the community representatives about the lengths that the staff go to meet people and to encourage them to access help and support. And I'm confident if the Thistle is not the place for him, they'd be helping him to access help and support in other places as well. We also heard about the anecdotal concern around an increase in people being there and faces that aren't recognised. It is quite difficult to capture that. Undoubtedly, though, and both your community representatives on the earlier panel were saying that this was an area where drug consumption was happening anyway. The drug consumption happens close to the market. This is an area, a long-established area where people come to buy their drugs. So it's difficult to capture just how much change there has been since the Thistle opened its doors in January. In general, safer drug consumption facilities reduce the level of crime and paraphernalia and street litter around the area that they are sited, and that's part of the purpose of them, as well as being a life-saving intervention. It is to reduce the harm experienced by individuals and the harm experienced by the community because of drug use happening within it.
Yeah, and I understand, Minister, where you're coming from, but this gentleman has said that it's the worst he's seen the East End of Glasgow in 42 years. Having been a pupil at a school down there less than 42 years ago, I understand where he's coming from. I've got family who live there. But my main concern as well is we've got, obviously, gangs in Glasgow who are have been in the news a lot recently, and these people are the people who are selling drugs in the streets. So what can we actually do to make sure that we make the community safe for those who are trying to abstain from drugs themselves, but finding a drug dealer on the corner of the street or outside the Thistle or in the surrounding area? And I'd like to get a wee bit of, just a wee bit of recognition as to that this is something that's happening now, and what can we actually do about it?
So I think it's really important that the concerns of the community are listened to. And I think that we heard again from the previous panel about the forum that's available to hear the concerns of the community around there. There is no doubt, I mean, the drugs market is entirely unregulated. There are, we don't have access to these drugs on any legal basis in Scotland. Organised crime is a huge part of the drugs market in Scotland, and there's a whole suite of work going on right across the UK to tackle that organised crime activity and to disrupt the market in Scotland. It is challenging. I mean, when we had that Four Nation meeting, one of the people attending from a justice background talked about a 75 million haul of cocaine that was achieved in Glasgow. So they took £75 million worth of cocaine out of the market there, and it made not a drop of difference to the market there. So that gives you some idea of just how resilient the market is and how resilient the supply is in some parts of Scotland, that even removing £75 million worth of drugs from it doesn't make a difference to the supply. So it is really challenging. We are up against, with the new synthetics, we're up against different challenges in that these are very potent drugs. So they're, as a paramedic described to me, what used to be a suitcase is now a matchbox size package of synthetic opioids. That means that they are able to get them into the country and in fact manufacture them within the country. So there is some manufacturing of synthetic opioids happening within the UK, not within Scotland as far as I know, but certainly within the UK. So disrupting the supply is undoubtedly challenging, and our justice partners are working really hard to stay one step ahead of the criminals who are causing such distress in our communities.
Thank you, Minister. Thank you, Convener. I might write to you on a couple of other points as well. Ministers, thank you very much.
Okay, thank you very much. I wonder if I can just come in with a final question, Minister. We discussed earlier the recent Scottish Affairs Committee inquiry into the Thistle project, and you've helpfully sent an outline of the Scottish Government's response to the recommendations that were made for both the UK Government and the Scottish Government. So I'm just interested in maybe any sort of further comments you want to make on the inquiry and the recommendations made, but specifically we've spoken this morning quite a bit about creating a smoking inhalation space, given, and obviously the Thistle Oversight Board, they've recently approved the development of a business case for this. So I'm just interested in broadly your kind of response to the inquiry recommendations, but specifically on the issue around smoking and inhalation.
So I think I've said before, that I agree with much of what the Scottish Affairs Committee have said. I think that they're right to encourage us to look at more cost-efficient models. I agree with all of that. It's very, very challenging in the legal environment in which we are operating at the moment, and without a wholesale review of the Misuse of Drugs Act, I think we have challenges with scaling and sustainability for facilities like the Safer Drug Consumption Facility. And that would be, I think, my main takeaway was, it's always frustrating to have people agree with you and still not have the power to change the situation that we are in. I think in terms of the second part of your question, remind me again, what was it?
It was just in relation to the specific point around smoking and inhalation.
Absolutely.
And obviously the business case for this that's been developed.
So the business case will go through its process. They'll need to work with the Lord Advocate on how that interacts with the Misuse of Drugs Act and the prosecution policy guidelines that were brought forward for the Safer Drug Consumption Facility. So the Lord Advocate will need to give a view on how possible that is, and what legal exemptions from prosecution are required in order to develop on that side. I think we've heard very clearly, though, from the clinicians operating the Thistle that not having inhalation, and this is about being agile, and my frustration that we do need to be agile to the changing pattern of drug use. So we've heard loudly and clearly that one of the barriers to coming in and using drugs in the Thistle is that people like to smoke at the same time as they like to inject. And I think that we need to think very carefully, again, in this whole challenging area of harm reduction, how do we best meet the needs of the people who would benefit most from coming across the threshold. So we would be supportive, and our officials will be supporting in any way that we can any changes that need to be made. I'd say there's a broader challenge, with the Misuse of Drugs Act and harm reduction around paraphernalia. So we spoke about, inhalation pipes. And they can't be supplied. And at the moment, what's happening, and you've heard it today, that people are injecting cocaine, and there's real risks because of the frequency of injection. There's real risks of increasing bloodborne viruses and sharing needles. There's real significant risks around injection site reactions to the extent of amputations. People can run into real difficulty with injecting 10+ times a day, particularly if they're becoming more intoxicated during the day. being able to supply an alternative, safer, less harmful means of using that drug, as in supplying safer inhalation pipes, would be a significant step towards harm reduction that we could take. But currently the Misuse of Drugs Act prevents us from doing that. I also heard from the people in the Thistle about tourniquets. You know, it's obvious to even lay people that having sterile injection procedures as far as possible would be a good harm reduction intervention, but at the moment they're not able to supply sterile tourniquets for injections because the Misuse of Drugs Act bars that.
So it would be safe to say, I suppose, that, and it felt as though in your correspondence to the committee that to a certain extent there's a common thread of challenge due to the fact that the Misuse of Drugs Act prevents some progress. And so should that be reviewed by the UK government, that would be very helpful.
Absolutely.
Yeah.
I would advocate for that.
Okay, thank you very
I'm not sure they're listening to me.
I sincerely hope they are. Okay, that just brings us up to time. Thank you very much indeed, Minister, and for your attendance this morning. That also concludes our evidence session in public, and we'll now move into private session. Thank you. Thank you very much.